Welcome everyone to Gut Over It. This is gonna be my jam for the week, actually. We did Shaggy last week. We're gonna do Yemi Alade. She's a Nigerian artist. She's singing Wonder Woman. Oh, superwoman in the building, we on fire, fire. Shout out to all of my ladies, independent women with a nature. Shout out to all the mamas. This is one of my favorite songs with my daughter. We love it. All about woman power. He's a designer. From the streets, getting moolah. Oh yeah, 1, 2, 3, Hello everyone, my name is Dr. Vivian Asamoah. I am a gastroenterologist in Katy, Texas. Thanks for joining me tonight on Gut Over It. Tonight we will be talking about something that's really important that you should be sharing with your GI doctor. This is probably one of the most important topics for your GI doctor to hear about. And we also know that it's one of the topics that our patients love to tell us about, but then they say, well, I don't know if I should go into detail. Go into detail. This is our job. We are GI docs. So often I will hear patients say, well, I don't know if I should be telling you all this, Dr. V. And then they look at me really odd, like really strange. And they say, why did you go into GI? Why? What was it about GI? Like I must have some weird fetish or something about poop. But poop is part of what we do, and defecation is a very, very important part of the detoxification pathway in the body, in the human body. It is a way for us to release all forms of toxins, all the crap we may ingest, unfortunately, and just really eliminate, right? And so we know that when we eliminate these toxins, it clears our mind. We know this because our patients who have liver disease like cirrhosis, when they start accumulating stuff in the liver, the way we treat them is actually by giving them a laxative called lactulose to help them poop and eliminate. Because if we don't do that, the toxins accumulate, go into the bloodstream, and then into the brain and causes confusion. So not having regular bowel movements is a bad thing. It is. So sometimes we'll hear our patients say, well, this is how I am. I've always been like this. I only poop once every 10, maybe 10.5 days. No, it's not normal. It's not good. So let's talk about what's normal. In terms of bowel frequency, let's actually even go, let's rewind. Let's talk about how to describe, talking about bowel movements with patients, with your doctor. It's not an easy topic and they have to bring it up. And I will say sometimes I've asked patients, how are your stools? And they're like, they're fine. They're fine. They're good. And then I say, and I can tell they haven't quite understood my question because they're here for maybe diarrhea. And then I say, well, how are your bowel movements? And they may say, she's good. She's very well. And I'm like, okay, they don't know what I'm saying. So I'm like, how are your poops? And then how's your poop? And then they get it. So when GI doctors say, how are your stools? How is your poop? What is the consistency? What is the color? What is the content? How are your bowel movements? That means what is the flow? Are you more constipated or are you flowing too regularly? Is your transit time too often, right? So we will see terms in the medical books and everything where they'll talk about how are your excrements? That sounds more like something we'd use for animals. Or how are your feces? That almost sounds vulgar, right? So we usually will say, oh, how are your stools? How are your bowel movements, right? And then we open the door and simplify it a little bit for our patients so they can just freely express themselves. And sometimes we get patients who have no issues with expression. They may come with, the great thing, photos. We love photos. We really do love photos. Take pictures of your bowel movements because, a picture says 1,000 words, right? So we can really tell from that picture when our patients are describing oh, the stools are hard, they're kind of soft, they're black, maybe a tinge of green. We love the pictures, especially when there's bleeding. So pictures up close and personal in the toilet bowl are always helpful to share. Now we have that technology, you can just show us, that's even better, okay? And, but we don't want stool in a plastic bag in the office. Sometimes we've seen that patients are like, wait, let me open, I have, and we're like, nope, COVID, we can't. It's the policy, we can't accept that. But really, we can't accept that because that's highly contagious. Like, where do we get rid of the biohazard in case you have an infectious, pathology? So I usually just say, no, I appreciate it, but COVID restrictions, we cannot allow that in the facility. Just, you don't want to hurt anyone's feelings. So that's what we say. So today we are going to talk about type, so consistency, color, and content. So before we get there, what's normal? So they say anywhere between 3 regular bowel movements a week to 3 regular bowel movements a day is normal. 3. So every other day in 7 days, that would make sense, where there's also a sensation of complete evacuation, like you feel satisfied after your bowel movement, light and airy and satisfied. And then 3 bowel movements a day can be normal for some because some people have a fast metabolism. Their GI tract is working extremely well. They've got great microbiome ecosystem. And as soon as they eat, they have a bowel movement, kind of like babies, right? As soon as they eat, not too long after, maybe less than an hour, they have a bowel movement and they're ready for the next meal. So that's actually even better. And we notice that a lot of men have that kind of regularity where they go 2 to 3 times a day. And unfortunately, a lot of women suffer from the constipation where they're going, every 2 to 3 days, which sometimes is an issue. Okay. Now let's talk. So that's what's normal. So if you're going once a week, it is not normal. It is not good for the body. And if you're going more than 4 or 5 times and the consistency there also is kind of mushy or watery, or some people say, I go 3 times a day, but it's never formed. That's not normal either. We have to find out why you're not absorbing enough water in, and maybe there are digestion issues as well, okay? I just want to take a minute to make sure everyone can hear me. If you guys are here for the first time, welcome. Thank you for joining us. This is Gut Over It. I am Dr. Vivian Asamoah, a gastroenterologist in Katy. I have committed to the month of February to presenting a short GI topic live every night at 9 p.m. So thanks for joining me. Please share some likes, show some love, leave in some comments, and let us know if you're appreciating it. I would love to hear suggestions for future talks as well. And so please share if you want to hear specific topics. So I'm going to go into this Bristol stool score. So again, of course, I'm just checking to see if anyone has questions, but I did make some friends. And I met 2 friends, John, I believe, and Lewitt, who actually came up with what we call the Bristol stool chart. So interesting, and I'm sure all of you have seen this chart whenever you've gone to your doctor's office, the Bristol stool chart, yes, from type 1 to type 7. So interestingly enough, this was invented in 1997. And I think I had just started med school. So what was happening before, I'm not sure, because we use this chart. This is like the GI doctor's Bible. We all have one in our lab coats. We just whip it up. What number are you, right? So I don't know what was happening before, but I'm so thankful to these 2 British guys who were doing a research study in the Bristol Infirmary and came up with this Bristol chart for future use in research. So it's been very, very beneficial in research to really be able to describe almost with exactitude the type of bowel movement someone is having. So, I didn't want to play with this whole share screen. The office team was telling me to go on Zoom. I said, I'm just going to go old school. Let's just get raw and basic with this. This is a raw and basic topic. So I had my son print everything out for me. Bristol's type 1. And he said, Mom, you better delete this when you're done. I don't need this on my screen. So here we go. Type 1. All right. These are hard lumps, like rocks, little pellets. This is what we call rabbit pellets. This is constipation. We don't like this. You're either not drinking enough water, okay, or you need more fiber in your diet, but that is not complete evacuation. I mean, you can tell by that, it's not complete evacuation. And then we've got type 2. Sausage shaped but lumpy. Again, this may cause some fissuration because it's got some bulk to it, but it's hard. So this means you are going to strain and strain and strain, and this may cause hemorrhoids. It may cause fissures. You know, we don't want that. You need to drink more water and hopefully more fiber, okay? Type 3, like a sausage, but it's got cracks on it, right? So it's more formed. There's a little more bulk to it, but it's still cracked. It's not smooth. The surface is not smooth. And so it's kind of still dry stool. It is constipation. Type 4, this is what makes us smile, right? Is sausage shape, right? Smooth, so easy passage, should not cause fissures, should not cause hemorrhoid swelling. This is nice and smooth. This should not take a long time. You're in 5 minutes, maybe 2 minutes, you're out, right? Nice and smooth. And then things start to change. Type 5, okay? Soft blobs with clear-cut edges. So this is the one that may come out full, like a whole form, and then once it ends up in the toilet, it breaks up into pieces. So this is abnormal, especially if this is happening all the time. So you let your doctor, GI doctor know it's BS, Bristol stool, BS type 5. Doc, it's BS type 5, okay? And your doctor will be like, what? Bristol stool, you didn't know that? All right, type 6. So this is fluffy pieces, you know, rugged edges, mushy. This is really mushy. It's coming out fluffy. It's not even formed, and it just breaks just after leaving the anal canal. It just breaks up, and this one probably splatters in the toilet bowl as it comes out. I can imagine a lot of air and gas coming out with that. Type 7, this is just water. It's water, it's entirely liquid, and it is just a puddle of water in there. So that is Bristol stool 1 to 7. I think those two British guys got it right. I think that is the spectrum of what we typically see, okay? So if you guys have any questions, let me know. I want to see if any questions are coming up, and I would be more than happy to answer. Let's see. All right. So a fissure, someone asked, what is a fissure? So a fissure is spelled F-I-S-S-U-R-E, fissure. If you can type that in, you remember what I said, go ahead and type it in. It is usually a cut at the anal rectal verge. So it's right at the anal rectal verge as the stool is coming out. If it is dry and if it is hard and you are straining to get it out, that external anal sphincter rips, like not the sphincter itself, but the muscle, the layer just before it, the tissue, the skin rips and causes almost like someone takes razor blades and slashes, right? And a fissure hurts, excruciating pain if you've ever had one. If anyone out there has had a fissure before, just say, yes, it is painful, or pain, it is very painful. And whenever you're having a bowel movement, you may have some bleeding. You'll really feel like you've got razor blades coming out of your anus. And even after the bowel movement, there's spasm like electricity right in that area. Very, very painful. So you don't want that. That's why you want to make sure you are BS type 4, nice soft stools, having a lot of natural fruits and vegetables, a lot of good fiber. So let's talk about, we talked about consistency. Let's talk about color. So I always hear lots of different things, and I want to start off with the color that really, really gets us concerned. That is the non-beet juice red. You didn't have beet juice last night. Don't send me a picture if you know you had beet juice, because I will get panicked. I will freak out. So, but we are worried about just kind of like a very maroon or fresh red blood. Now, the very fresh red blood could be, and small amounts on the toilet paper, could be coming from a fissure or hemorrhoids. But when we see a maroon color, like a deeper, like a much deeper velvety burgundy red, there we go, it's most likely coming from the right side of the colon and traveling all the way down, or even from the small intestines, the end portion. And that's concerning, okay? That usually warrants investigation. So for that, we'd want to do a colonoscopy for sure. Check your blood counts and make sure everything is fine, especially if it's happening multiple times in a day or over several days. So maroon colored stool that's, or just what looks like maroon colored blobs coming out with some redness, red tinge, that's blood and that's concerning. If it's bright red blood as you wipe, it's most likely hemorrhoidal, but today, we're not taking that chance. You could have hemorrhoids, but we're seeing an increasing number of colon cancer in our younger population, right? People who we would have said, oh, probably hemorrhoids. We're actually finding cancer. So we always, at least over the age of 30, we're going to perform either a sigmoidoscopy or a full colonoscopy. Okay, so this is really important to everyone out there. If you've noticed rectal bleeding that's new, it's fresh when you wipe, it is still important to see your doctor and get a colonoscopy, because can you have hemorrhoids and something else? Yes, there could be two things going on. So at least once that full colonoscopy is done and they only find hemorrhoids, we're then confident that that's all we need to treat, okay? So we talked about hemorrhoidal bleeding, a little bit of red, can be drip in the bowl as well. The darker maroon colored bleeding, and then sometimes you'll have fresh red blood that's just coming out. Like patients are like, every time I go to the toilet and I just pass gas, there's just red blood just coming out. Now, sometimes we'll see that in people who have diverticular disease. Those little that's a good topic to discuss, right? That's a great one to discuss. We'll have some time to talk about diverticulosis, but sometimes whenever you have a painless rectal bleeding that is significant in quantity and ongoing over days, diverticular rectal bleeding, you must go to the emergency room. You must call your doctor and you must go into the emergency room, because that can be profuse bleeding that is difficult to control. And so when we have someone come in with diverticular rectal bleeding, we scope right away. We don't even necessarily even do a prep. We go in right away and we try and identify the little dimple or the pocket that's bleeding. We can put clips, we can inject medication. We just try and control the bleeding. If not, you could lose pints of blood and require blood transfusion. Okay, so that's important. Let's move on from the red color to the black. So I've often hear patients saying, my stools are black. They're black. And I say, well, are they black and mushy like tar? And they're like, no, not really. But they're black. They're like little balls, little pellets, and they're all black little pellets. And I say, well, that's constipation. That's dryness in the stool, right? So the difference with that is we get concerned about black because black can be digested blood from the small intestine. So anything from the stomach or even down the food pipe to the stomach, to the small intestine where digestion happens, because the enzymes will digest the red blood cells and the heme in it and release a very dark black color. And this color, I thought I printed something out, and this may not be great, but it's typically like this. You see there's a red hue, but it's black. And this, when we say, is it black like tar? There we go. Is it black like tar? That's it. It's black. And this, any doctor out there will tell you, this is probably the worst smell, the smell of digested blood. We call this melanotic blood. If you close my eyes and put me in a perfumery, Sephora, and give me a whiff of that melanotic, as a GI doc, I'm like, someone's bleeding up in here. So this is melanotic blood. This means there is active bleeding going on in the GI tract. So we want to do an upper endoscopy to identify and treat, okay? But then some people will say, my stools are blackish green. Blackish green is a little different. So that sometimes, especially if it's diarrhea, could be related to an infection. And very often if there's a strong, like a bacterial infection, like a gastroenteritis, and very often if there's a very, very strong smell associated, we can sometimes think of a diagnosis of C. diff, so the Clostridium difficile colitis, which is a common bacterial infection of the gut and the colon, usually after an antibiotic treatment, right? So C. diff, think of C. diff with black, greenish, tarry, very, very, very smelly stools, okay? A great question. I was just about to talk about iron. So there are a couple things that will change the stool color. So iron is one. It will give you a grayish color to the stool, still formed, but we also know that iron changes the consistency of the stool, okay? Makes it a lot more harder and drier. Another thing that will change the color is Pepto-Bismol, everyone. So Pepto-Bismol will also give you a grayish color or blackish color to the stool, okay? So just remember that. And I don't want to go on for too long. I didn't realize how much there was to talk about stool, probably because I'm a GI doctor and I love stool. But it gives us so much information. Finally, I want to add a little bit of information about, we talked about consistency, we talked about color, let's talk about content. We talked about the blood, but I want to talk about, color, clay-colored stools. I don't want to forget that. Clay-colored stools could be a sign of gallbladder disease, right? There is something called stercobilinogen, yes, in stool, and that gives us this clay-colored stool. That means we have to investigate the gallbladder. So whenever you have someone with clay-colored stool and tea-colored urine, it could be a gallbladder issue. Okay, so let's keep that in mind. And then a few things I hear my kids up there, they don't want to go to bed, but they know I'm here, I can't go up there. But finally, I will add, so I can get back to my mommy duties, mucus in stool, all right? So there are goblet cells, and these are these big puffy cells that make mucin in the colon, and they release mucin, which helps create some lubrication of the stool so that when it's coming out, it's all nice and smooth, right? And so that's normal. And we'll see that in people with constipation. They'll be like, I had a hard bowel movement and there was some some mucus following that. It's normal. Your colon is just trying to give you some help to get that stool out. But then there's mucus that looks more like mucus, inflammatory, and that's mixed in mushy stool. That's mushy diarrhea. That could be inflammation, right? Inflammation-driven colitis that gives you that mucousy stool. So our patients with Crohn's disease and ulcerative colitis who have proctitis have that mucousy stool. That's not good. Let me see if I can think of anything else in terms of content, like what's mixed in the stool. Oily. Oh, there's so much to talk about, so much. All right, so an oily emulsion. So when patients say, I had a soft loose stool, maybe a BS 5 to 7, and when I flushed or when the stool came out, there was an oily emulsion, like someone poured palm oil or avocado oil, and I couldn't flush it down, that's fat malabsorption, right? So there's a problem with the pancreas or the gallbladder. Very, very important. This is probably one of the most important lectures I will give on Facebook Live, but about my career, but very, very important for you to look when you wipe and look in the bowl before you flush, because you'll be able to see changes, consistency, different things, okay? So it's very, very important. And I truly, personally, as a gastroenterologist, do not believe that anyone can be obsessed over stool. I mean, you have to be. It's very important. So share this information with your doctor. You can talk about consistency, you can talk about color, you can talk about content, share all of this important information with your doctor, and please make sure that you look at your stool on a regular basis. Let me see if I can take one more question. Make it difficult and guess. Oh, some people say, well, what makes it hard for you to just ease yourself, right? And sometimes you only have gas coming out and you're not able to get stool out. It could be that you're not getting enough water, you're not getting enough fiber to bring bulk out, right? Or you're overproducing gas. right? And that has to come out first, all right? So, but usually it could be that it's dry, it's not coming out easily. So I hope this was good information, guys. Again, my name is Dr. Vivian Asamoah. I am a gastroenterologist and functional medicine provider in Katy, Texas. If you enjoyed this, please share it with, give it a like first, but please share it with someone who may be having some bowel issues, right? Some stool issues that, can't really describe it quite well to their doctor. A picture tells them 1,000 words, so let them take a picture. Love us on Facebook, leave a comment, and if you have any future topics that you want us to discuss, please share them with all of us. Again, have a wonderful rest of the week. Tomorrow, I'm not sure, I think we have diagnostic testing in GI, the different tests that you can do to work up different issues, GI issues. So we'll be sharing that, I'll be sharing that tomorrow at 9 p.m. Have a wonderful evening, guys. Bye-bye.